We
Cool.
go.
I don't know if I can hear you. Hi, everyone. Welcome. Thank you for joining us for part 3 of our workshop series, STI service integration into incarceration facilities or correctional facilities. This part 3 is going to focus on assessing impact and evaluation of the services that we've been providing. If you don't know me already or my face, my name is Sonia Khan. I am the Senior Manager of Disease Intervention here with NCSD, and I'm joined by Erin Sonato. Erin, do you want to introduce yourself?
Yeah, hi, I'm Erin Sonato. I'm a Senior Manager of Program Evaluation here at NCSD.
So we'll go ahead and get started. Just a couple of housekeeping items before we get too deep in. So this is the third in the 3-part workshop series, and I'm aiming to have recording and slides available on Friday. If you haven't seen yet, or if you missed part 1 or 2, the recordings and slides are both available. I believe I put the link on the last slide of our presentation, so you can grab it then, or you can also go to our website, ncsddc.org, and go under events, and our STI service integration workshop series is actually the first event listed under there. We are in meeting mode, so I think it auto mutes everyone, but just in case, just for us to be mindful about staying on mute. And if you have a question, please, we invite you to enter it either into the Q&A. There's a Q&A button that's kind of center bottom, if your toolbar is on the bottom, or you can also enter it into the chat feature, where you can chat with anyone who's in the meeting, or any of us, either myself, Erin, or Leo directly, if you have something specific. If you have any accessibility needs that you'd like to share that you haven't shared yet, please feel free to message directly Leo Parker, or you can email him. His email is listed here at lparker@ncsddc.org. And at the end of this survey, at the end of the meeting, there will be a post-meeting survey. We really, really appreciate the feedback that you all have shared thus far. And if you all can do it one more time for us, that'd be super. Some of the questions that you all shared in the second part and the first part, we are going to cover here. And if we have not covered it yet, there will also be a service delivery toolkit that we're aiming to put together by the end of July as well. So just an overview of where we're going to go for today. I have another typo on the slide. I will fix it. But for our goals, I just want to go over our goals real quick, a recap of part 1 and 2. And then I'll turn it over to Erin, and we'll go over what's next.
Yes. Do you want me to talk about this part, or do you want to talk about this part?
Sure. I can just recap it. And then if you maybe want to talk about the next one. Sure. About specifically for this one. So just to recap kind of where we're at for the goals for the whole workshop series. In the first part, we focus on identifying needs for partnerships, staffing, and resources, and some of those more tangible resources that we needed to integrate services. In the second part, we focused on identifying logistics to effectively implement services. And then this one, we're going to focus on assessing ways to measure impact of service delivery. And now I will turn it to Erin.
Perfect. So we have some learning goals for today for part 3. The 2 specific goals that we're looking at today is understanding the importance of assessing impact service delivery. So we're going to talk about, why do you want to do evaluation? Why do you want to assess impact of the program? It takes time, it takes resources. It's not necessarily the most fun part of the project, but we're going to talk about why it's so important. And we're also going to talk about utilizing data collection tools to fine-tune and expand services. So we're going to talk a little bit about data collection, tips and tricks for data collection, and some best practices.
Thanks, Erin. So just a quick recap of part 1. So in part 1, we connected with Public Health Seattle and King County, where we heard from Dr. Dombrowski and our DIS Luis Enrique, where they pilot tested syphilis, HIV, and HCV testing in their local jail. They talked about their implementation process and what their follow-up was for reactive test results for both treatment and partner services. They did note that relationships between the jail programs, staff, and health services are key, and that treatment completion is still a challenge that they're working to close the gap on. In part two, we heard from Erin Fratto, who is a TA consultant here with us at NCSD, on 340B basics. Erin talked a little bit, just a high overview of 340B, and in our service delivery toolkit, we'll include some more information that she's created, specifically supporting 340B, questions that you all may have. Specifically, incarceration facilities must partner with a hospital or federal grantee, which includes us as STI programs or FQHCs, federally qualified health centers, to be eligible to receive 340B funding. So 340B funding, it is a partnership to provide medication. The correctional facilities must receive direct financial support or in-kind contributions to be eligible. Some of you had asked, well, what do these in-kind contributions look like? Fear not, Erin has created a list for us, and we will be sharing that with you. If you missed it in the chat that day, I will include it in our service delivery toolkit. She also talked about the medications that are covered as part of 340B eligibility, and then how patients become eligible within the incarceration facilities once the incarceration facility is enrolled in the 340B program. We also heard from Pueblo Department of Public Health and Environment and Colorado Department of Public Health and Environment, from Corey Westwood and Elsa Huber, who is their DIS, where they specifically focus on congenital syphilis prevention. And Corey actually tests and treats the folks there. So kind of the highlights from their presentation, they identified 27% of people that were tested actually tested reactive for syphilis, of which 25% of people were pregnant and 73% of people completed treatment. They also talked about field delivered therapy successes in preventing congenital syphilis and some of the cost savings that their partnership has provided for the incarceration facilities. So if you missed any of that information in detail, this is a very high overview. Please feel free to go back to the slides and recording again. The link will be on the last slide here once we get towards that end. And I will now turn it over to Erin.
Great, thank you, Sonia. So we're going to dive right in about why do we want to assess impact? Why do we want to see, why would we carry out an evaluation or an impact assessment? Sonia, can you, next slide? So first and foremost is we're looking at data-driven decision-making. So we want to evaluate our program effectiveness, and we can use data to make these decisions to inform resource allocation, to talk about sustainability and scalability of your program, and to do learning and improvement. So when we're looking at data, when we're doing the evaluation, when we're looking at areas where we're incredibly successful and where we might need a little bit of tweaking, we can look at where our resources need allocated. And that can be human resources, it can be funding, it can be test kits, it can be where your program is operating, but figuring out where resources are most needed through data analysis. We can also talk about sustainability and scalability, which we will get into a little bit more into the later parts of the presentation. But it's really important to think about the fact that telling a story these days isn't enough in and of itself. Telling a story with data through a grant application, through an annual report out to constituents, through reports to decision makers, data really helps make a difference in buy-in into your program and buy-in into what you're doing for your clients. And it also gives you learning and improvement. So it shows where you might have areas where you need to grow or change, and it actually shows you areas where you can improve, and it might help you come up with ideas for improving your program as well. Next slide. Another reason to assess impact is accountability. So the first thing we talk about is stakeholder engagement. And when I talk about evaluation, stakeholder engagement is one of the key components of carrying out a good evaluation. And CDC actually has a 6-step approach to doing program evaluation. And the first step is engaging your stakeholders. So when we think about stakeholders, we typically think about those decision makers, policy makers, funders, but we also want to think about the people that we're serving as well. We want to engage those people that we're serving into the evaluation and into the changes that you're making into your program. It helps you build trust and integrity throughout all stakeholders. So your decision makers are going to have more trust and integrity if you are assessing impact, as well as the people that you're serving. It offers some transparency into your program. And of course, compliance is a big thing. So if you have funding that comes with compliance points, if you have a grant from CDC or another governmental entity, maybe it comes to your state, you're going to want to be able to collect the data to do that grant reporting to show that your program is running effectively and helping those who you have committed to helping. Next slide. And finally, we talk about policy and advocacy. So when we talk about data, we really talk about evidence. So we can see that providing evidence to support policy changes is really important. Again, telling a story is different than telling a story with data. When you're talking about making policy changes, and this can be at a number of different levels. It can be policy changes within your own program. It can be policy changes within maybe a larger program in your health department or organization. Or it may be huge, big P policy changes that we're trying to drive maybe through a legislature, but having the data to substantiate and back that up really helps. It does demonstrate the effectiveness of your intervention. It can influence policy decisions, and at the highest level, it can drive broader systemic change. Next slide.
So looking at this a little more closely, narrowing down to where we're at. So data-driven decision-making, what does this look like in an incarceration facility if we're integrating services? So firstly, are we identifying enough positive cases of infection to be impactful? When we're thinking about that, we also want to think about who we're identifying. Are we maybe identifying people who can become pregnant and preventing cases of congenital syphilis? Are we reaching people possibly that we may not reach otherwise if they were not incarcerated? Kind of looking at some of those positive cases, but also who we're reaching with those positive cases. Looking at what is more valuable in the context of maybe our resources or our time or access to folks, rapid testing versus blood draws, and what is working for the DIS and what isn't. One of the things that in our first part, Luis Enrique, our DIS, he went into a little detail about how he troubleshooted, hey, this isn't really working, we need to try to tweak this. And so keeping those things in mind as we're implementing, refining, and moving through some of these processes. Under accountability, are we providing equitable care that looks at not only the quality, but who are we serving? Are we working to close gaps in people who are adversely impacted by syphilis and HIV? And then for policy and advocacy, this sometimes can sound a little intimidating to us at a program level, but this is actually really applicable to us. So maybe this is something as kind of tidy and neat in a box that we do very often, but it really is a form of advocacy, is do we need to conduct provider detailing with maybe certain area providers to encourage better testing, or maybe better testing during pregnancy and delivery? So that can specifically look like, hey, maybe we need to connect with our local emergency departments or our local OBGYNs to encourage testing at 28 to 32 weeks delivery, not just the first prenatal visit, if there is one. And then do we need to look at providing more comprehensive services in incarceration facilities? So for example, maybe we're just testing right now for syphilis. Do we need to maybe think about including hepatitis C testing?
So evaluation is pretty broad, and what you can do with evaluation, it can be many things. So when we think about when should we evaluate, the first statement that I always make is you should think about evaluation before you implement your program. And you can think about that in a couple of ways. One is building an evaluation program while you build your program. So thinking about what data you're going to collect and how you're going to collect that data and what you're going to do with it, so that as you implement your program, you're collecting the correct data to make your to build credible evidence around your program as it goes on. So you can evaluate before implementation. You can do a needs assessment. So you can assess your needs, resources, feasibility, and effectiveness of your program. And you can ensure that your program is aligned with the needs of the priority population that you're working with. So if you're doing evaluation kind of in a vacuum before implementation, it's really that needs assessment to see what your needs are before you start planning. It helps you get more organized, and it helps you really pinpoint what you're trying to do. During implementation, so we've got the program rolling, it's the activities are happening, we're going to try to identify areas for improvement and ensure that the program is being implemented as planned. Sometimes we start to veer off a little bit, and if we're doing evaluation, we make sure that we're meeting those core requirements and core needs of the program. After implementation, you can assess the effectiveness of the program and identify any unintended outcomes or impacts. So this is a big one, that you would use that data that you've collected throughout to assess the effectiveness of the program, to try to find out where you have really succeeded and where you have some areas for improvement. This may come out as a formal report. It may help you build your next grant application for continuation funds. But it'll help you have a more comprehensive idea of what happened during program implementation. And then you can also evaluate at regular intervals. So you can monitor your program progress and identify areas for improvement. And importantly, ensure your program remains relevant and effective over time. So we can start a program in, let's say, 2019, and our program's going great. But if we don't tweak it through the craziness of 2020, 2021, we're going to lose some of our relevance and effectiveness. So if we have something big like COVID or impacts happen, we need to be responsive to that. And evaluation can help you be responsive and make changes, whether it's something huge that you're reacting to like COVID, or whether it's just something like the populations that you selected at the beginning of the program may be added to or changed as you go on throughout the life of the program. I think Sonia's going to talk a little bit more about this.
Yes, and I'm sorry if my internet, I hope my internet doesn't cut out, because we might have that. Hopefully. But narrowing in again a little bit, kind of applying what Erin is discussing. If we look at kind of where we're looking at the before implementation phase, during implementation, and then at regular intervals, this is kind of the format that this webinar has taken, this workshop series has taken, where before implementation, these factors that are listed here were really the items that we looked at when we were looking at planning for partnerships. So what data do we need to support testing in incarceration facilities, whether that is for staffing purposes or to justify with senior leadership, but hey, there's a need for this that we need to be supporting in our community. Once we've identified who the key partners are, or the potential key partners, what is their accessibility? What is their capacity to partner on integrating services, and what sort of buy-in maybe do we need to garner from them in order to be successful? What resources are going to be required? Again, whether that's staffing, whether that is maybe security clearance, if we already have DIS that are able to do this, do we need an additional maybe clinical staff that can support with treatment delivery? And what services are we going to prioritize? Will it be just syphilis testing? Will it be just HIV testing? Or will it be similar to Pueblo County, where they prioritize just people who can become pregnant in order to prevent congenital syphilis? During implementation, a lot of this information will come from someone who does the testing in the incarceration facility. So a lot of times that will be DIS. So DIS may be responsible for noting how many new infections are we identifying. How is the treatment being delivered? Is it being delivered within the incarceration facility, or does DIS need to follow up with them afterwards? And also looking at the quality and success of partner services. Are we just looking to make sure that we are ensuring treatment for folks once they test positive, or do we want to also try to get at least one named partner so that a DIS can follow up? And then at regular intervals, where Erin was kind of discussing responding to maybe changing factors, So what challenges are happening with testing, treatment, or partner services? Are we finding that maybe a lot of people are being released before we have the opportunity to even let them know that they've tested positive with an RPR, and that we will be following up? What does that look like? And then how many new infections do we have we identified over a set period of time? I did not include in this specific graphic the after implementation, just because that's a question mark, I think, that comes from the programmatic perspective, and that will differ from where we're all at. So before you want to begin testing, you'll want to kind of identify maybe a 3-month period or a 6-month period in which we want to reassess factors that were there before we started testing, and then maybe reassess again at 6 months to see how that will look. And so that kind of ends up being at regular intervals, but we'll talk a little more about sustainability a little later on.
So we'll talk a little bit about standardized data collection and how to collect data. This is kind of like data collection 101, just to give you a primer on good practices for collecting data. Next slide. So you want to start with clear objectives. Sometimes what I see happen is data comes out of like a brainstorming session, where it's like, we would love to have all of this data, it would be great. And that's a good first step, but we really have to refine that down to really collect only what we need. So you want to start with clear objectives as to why you're collecting data. You really want to think about the reasons that you need data points. One thing that I do is I think about, what would this look like in a final report? So if I'm collecting clients' names, I wouldn't necessarily use that in a report for a number of reasons. One, I can't really condense that variable down into a reporting point, and two, it's sensitive information. So we really want to think about the reasons that we're collecting each bit of information. You want to clearly articulate the purpose and goals of your data collection efforts. You want to focus on that specific information that you need, and you want to guide the data collection process. So you want to really focus on how you're going to collect this data and the feasibility of collecting data. I have some notes down here. Do you need to collect personal information? Of course we do, but what sensitive information do you need to collect? How are you going to handle that data? You may want to talk to somebody within your agency that deals with personal protected information to understand how that needs to be handled. And you really only want to collect what you truly need for a number of reasons. One being that collecting data is burdensome. It's burdensome to the person collecting the data. It's burdensome to the person whose data is being collected. And you have a large data set that is more cumbersome than something that is smaller. It's harder to keep clean data sets when you have 70 variables than when you have maybe 17 variables. So you really want to narrow that down and make sure that it has purpose behind it. Next slide. We want to maintain data quality. So messy data is something that's very hard to work with. We want to train our data collectors on how to collect data. We want to do regular checks for accuracy and consistency. We call that data cleansing. And you want to document the data collection process. So maybe have a job aid or a protocol for how that data is being collected. I had one more thought here and I've lost it. I apologize. So we'll go to the next slide, and when it comes up, I'll bring it back up. We want to develop well-designed instruments. So instruments can be a lot of things, but for the most part, and for our purposes here today, they're going to be forms. Whether that form is an online form or a paper form or maybe something on an iPad, we want to develop these instruments well so that they collect standardized data. So you want to ensure your data collection instruments are clear, concise, and relevant to your objectives. You want to keep them short. You want to keep them standardized. So if you are updating your form, make sure everyone gets an updated form so that you're still collecting standardized data across the board. Just reiterating that you only want to collect the data you truly need. One thing that I always encourage is whether you're using a paper form or you're using an online form, you want to use drop down or multiple choice options to standardize responses. We don't need responses being put into different formats. We really want to keep them in one format so that yes is yes all the way down the column. It makes it a lot easier to work with that way. And I also recommend piloting these instruments just to see if there are any issues or improvements. So you can hand them to your DIS or whoever's collecting information. Let them start by looking over it to identify any pain points or any issues that they may see, and then pilot it with some clients to see how that goes. Come back and discuss and maybe tweak it to get the final form that you really need that's going to work best for you. Next slide.
Sorry, everyone, all my screen. Are you still seeing my screen?
We can still see your screen, yes.
Okay, great, but you can't see me.
We cannot see you, no.
Okay, great. I'm gonna keep my video off for now, just because my computer keeps telling me it has low resources.
Okay, yeah, everything looks good for now.
Okay, great.
And we can hear you fine.
Cool. So narrowing down again to where Erin left off. So what does the data collection look like? Not oftentimes this will be done by the person who is testing, who will more often than not be the DIS. And just like standard DIS work, oftentimes it is our responsibility to identify possible trends. So what lifestyle factors are we possibly identifying with people that we are testing that could contribute to positive tests? Are there clusters? Are there social networks where we're seeing trends? And then what does that positivity rate look like? Some of these things will be anecdotal, like many of the some of the information that we do collect as DIS and we indicate in our documentation, in our case notes. One example of this is I had a team, one of my DIS, she actually tested in the jail, and she tested someone that tested positive for syphilis, and they lived on the reservation. This person said that they had sex with someone who was pregnant. Concurrently, someone else on the team, another DIS, said, "Hey, I just tested 2 people, or I just came across 2 patients that I now have who also said that they live on this same reservation, and they've heard rumors of someone who is going around having sex with a bunch of people." So while we know as DIS, sometimes these things are a stretch, but also we do need to provide merit to them to a certain extent. So looking at some of those things as data collection points. Just like any other individual that we're testing, we're going to collect patient info, and we're going to look at specific factors that could be contributing to trends. So is there maybe drug use? What kind? How are they using drugs? Is there maybe sex work involved? Risk factors that may be contributing to reactive tests, maybe housing status. We also want to be mindful of notating testing history, both reactive and non-reactive, and if they've ever tested either way, if they've had treatment, whether preventative or not. Any signs or symptoms present that they've recalled or that they may have, and any exposures that they suspect. Also, we want to think about locating details. If we know the person's release date, we want to keep that in mind, and then how to find them after release. And in the big picture, how these things kind of come together in data collection, if we recognize that people are being released maybe within 4 days of being tested, maybe we go as DIS to test them, and then within 4 days they're released, we maybe need to come up with a better way to make sure that we are able to connect with people once they are released.
Sonia?
Yes.
I think your slides are stuck. Would you mind pausing your share and let me share my screen?
Yes.
Sorry, everyone.
I'm going to stop. Okay.
Okay, I'll share. Just give me 1 second, please.
Thanks.
Okay, there we go.
I'm going to actually minimize this so that I can. Ooh. Thanks for your patience, everyone. I don't know where my screen went. I can't see you all, but here we are. Okay, yes. So secondly, yes, data collection. So that first part was focusing more so with our patient interaction. There's also going to be a second set of information that we want to be mindful of post-testing. So this is when we've collected our materials, we've gathered our specimens, we are back at the office, and we are entering in our documentation. So we want to be mindful of trends in testing to really assess the efficacy of the intervention, the testing that we're doing. So maybe we notice that on, for example, Wednesdays, we're able to test more people because Officer Joe is working instead of the other officer who doesn't really care for us, but we built a great relationship with Officer Joe. Another thing to be mindful of is, what is the testing impact when I test as a DIS or a public health worker versus maybe the jail health services testing? Is there a better outcome when I test as a DIS? Maybe I bring some candy along versus jail health services doing the testing at intake. Maybe we notice that at meal times we're unable to test more people because folks want to eat and they don't want to necessarily get out of that, but maybe people do want to get out of some X activity that they have to participate in. And then also thinking about one thing that Corey and Elsa had mentioned in part 2 was how they changed the language to encourage more people to want to get tested. So they made it opt-out testing for syphilis rather than asking folks, do you want to be tested for syphilis? So kind of manipulating that language in a way that encourages folks to want to be tested to make sure we're reaching more people. And then when we're looking at treatment, so now we're documenting, we've identified maybe a couple cases, a couple people who have tested positive. And what does that treatment completion look like? One thing that Public Health Seattle County had mentioned in part 1 is that was a challenge for them, is that ensuring folks are getting complete treatment. On the other hand, Pueblo County said that 73% of the folks that they were testing actually received complete treatment. So what are some things that kind of go into that? And then what does the timeliness of treatment look like? Also, who is testing? Is it jail health services that's testing? And is that more successful when maybe folks are being tested, treated right while they are incarcerated? Or is it a better outcome when we follow up as DIS post-release for them to get treatment? And then again, that piece of, when is treatment happening? Is it during the time that folks are in the facility, or is it post-release followed by DIS?
So when we talk about looking at trends and looking at data, standalone data can tell us some things. It can give us some baseline information, but comparison is really important in evaluation. Comparing one thing to another shows change, and we really want to talk about what change is happening in our program. So you can look at, I say local data, but it can be your local program data. That you can maybe look at the epidemiological data that you're collecting, maybe demographic data, maybe behavioral data, and compare that at the local, state, and federal level and see what the difference is. In the yellow one, I'm talking about looking over time. So seeing how your program has changed, how many people you've treated in year 1, year 2, year 3, or maybe month 1 to month 12, how it's changed over the course of a year. You can look at demographic information for everyone you test and compare that to positive clients, and then look at state or local epidemiological reports. It helps you see a disproportionate effect of, it could be disease burden or populations that maybe your program's missing that we need to look into more outreach. And then we can compare demographics, so seeing disease impact or other impacts on different age groups, on different race groups, on different genders, and see how things have changed. So you can do some comparison in a lot of different ways to check and see how your program is being effective. So sustainability planning.
Yeah, so I wanted to actually get an idea. Erin, can we go back for a second, actually?
Yeah.
Just landing slide. So before we get into just some conversation around sustainability planning, I thought it might be a good idea for us to kind of get an idea of who all is in the room. If you were in one of the previous conversations, you probably have seen this exact poll. I'm going to go ahead and launch it. So firstly, which best fits your role? Are you a DIS? Are you some type of DIS supervisor? Did it launch or is it not going to?
Yes, it launched.
Okay, great.
I'm
Yes, are
starting
you
to see
DIS
some responses
supervisor?
come through.
Or are you clinical? And then secondly, what stage of implementation are you in? In our last conversation, it looked like there were about a third of folks in the conversation that were in each of the planning stages. So just kind of as we're looking at a high overview here of where we're at in this part to get an idea of where folks are. And while you all are completing this poll, maybe we can use this time. If you all, I know that was a lot of information on kind of looking at the macro and the micro. So are there any questions right now before we move into a little bit more of the planning for sustainability? If you have questions, feel free to questions, comments, ideas, thoughts, feelings, go ahead and we welcome them for y'all to put them in the chat or the Q&A.
Sonia, real quick, I don't see any questions in the chat, but I do want to share something that Barry Z put in the chat that around the incentives, which is a great idea on the inside, but just wanted to remind everyone to please get permission to do that because it could be considered as contraband in some locations. So just wanted to put that out there since we were talking about some of that information and didn't want to wait until the end of the presentation because I thought that it was really worthwhile sharing.
Yeah, thank you, Barry,
Leo.
for adding that, and Leo as well for bringing that up. That's a really great point. And I don't know if it was just me, if my audio was low, or if others had difficulty hearing too. Maybe it was just me. I think it looks like most folks have answered the poll. So it looks like almost 37% of folks here are DIS, which is great. So DIS, if you have questions kind of specifically about what that data collection looks like or what your role looks like in this, please feel free to ask away in the chat or in the Q&A. We also have a good number of folks here who are STI program managers and something else. If you'd like to share what the something else is, feel free to drop it in the chat. We'd love to get some insight into how you all are supporting some of this work. And secondly, what stage of implementation are you or your program in? Looks like 30% are considering the need for integration, with the second largest being in partnership development. I'm going to go ahead and end this poll. Thank you all for sharing where you're at. I'm not sure if you can see this before, but I'm going to share here. All right, cool. I'm going to close this out. All right, I am ready, Erin.
Okay, great.
So one thing that we really should be thinking about from the beginning when we're thinking about how are we going to expand our services is how are we going to make sure that this service that we're providing is sustainable and accessible to folks who need it most. And really, we want to be using the data that we're collecting here, both pre-implementation and during implementation to plan for that. So firstly, well-organized and maintained data protects programs from heavy budget cuts. So we know that if we are routinely collecting data and organizing it, maybe let's say on a monthly basis, we assess here are how many folks who have tested positive, here's the demographic information, here's their risk information and lifestyle information, and here's the impact that we're having. These are simple yet very effective tools in protecting existing programs. The data that we collect that is processed and available on a monthly basis, we want to have the capacity to do basic analysis and for it to really tell a story. And it doesn't have to be complex analysis. We don't need SPSS, we don't need SAS. We could just do a quick little Google, a little Excel graph in there, and we don't even maybe need to do that, because again, some of this data is going to be anecdotal, like what I had, like the example I had shared about the potential cluster that we identified of syphilis transmission that was happening in a section of the reservation. And again, this is information that us as DIS we are familiar with. It happens during Chalk Talk. We're familiar with how some of these really, really useful information actually reveals itself during Chalk Talk when we're having these conversations with one another. If you are maybe a manager here, we obviously want to be mindful of maximizing our investments, not only our staffing investments, but also the monetary and tech investments that we make into any new testing initiative that we make. And I think one thing that maybe gets left behind a little bit, given limitations within our the settings that we work in, is being mindful of the fact that discontinuation of services without planning or intention to can really result in future obstacles to mobilization. So, for example, let's say that abruptly we stop testing in the jail because it just kind of fell off of the to-do list. Maybe there was, several congenital syphilis cases or maternal cases of syphilis that we needed to address, and it just fell off. We didn't have maybe the people to go test or whatever. We should be mindful of how that may impact future efforts. So maybe later on down the road, we may want to restart testing in incarceration facilities, but what was the impact that we had in abruptly stopping to begin? What resources did we maybe lose in that lack of maybe communication or just intentionality when we are thinking about that? So maybe if that is something that has to be done, having those conversations and future plans in place so that we can continue that partnership. And so now we've talked a lot about, here are a lot of data points, here's a lot of information that we can collect. How are we going to use this information? What do we do with all this information? So there are a couple of things that we can do. We can use this data firstly to expand the services that we are providing. So maybe we've identified, maybe the DIS has identified that, hey, there are a lot of folks here that use intravenous drugs. Perhaps we should consider including hepatitis C testing, and that would really be an expansion of services. Programmatic extension of that could be, well, we're identifying that there is a lot of IV drug use. How can we maybe start a syringe exchange program outside of the facility that can support the communities that maybe are transient or experiencing houselessness or maybe using that could end up incarcerated? How can we support those folks in between with a resource that's available in their community? Or do we possibly need more testing in this setting? Are there populations that we are not reaching? Secondly, we can look at improving the quality of services. So looking from a health equity standpoint, do we need more specialized outreach? Maybe is there kind of, again, do we need to support syringe exchange outside of the facility or maybe within incarceration facility? Who is testing? Are there folks that we are not reaching within the facility? And what is the reason for maybe not testing? How can we close that gap in quality and access to care that is being provided? We could potentially explore enhanced by-cell delivery. So maybe we have a clinical person who is also a DIS that is able to deliver bicillin in the field or in the jail setting with the appropriate, appropriate permissions is the right word. And then also thinking about how the treatment happens, whether it's with a public health nurse or is it jail health services, which is going to provide the best quality of care. And then we could also think about expanding to substance use disorder treatment referrals. Erin, did you want to add something to these before we go to the next slide?
No, I think you've got it. Thank you.
We have a second number 2, so really a number 3 and a number 4. So using that data to demonstrate the success that we are having to request funding. So for our manager friends here, this is going to look like including those specific data points in grant applications to strengthen grant funding requests. And then for DIS, that's going to look like us sharing the data that we find both anecdotally, between presumptive interviews and interviews, potential clusters we may identify among social networks, and relaying that information with our DIS supervisors and our managers so that they can emphasize the need for funds. Really, it's our role as DIS to be aware of these things so that we can inform the decision making that happens higher up in leadership. And then also demonstrating continued need for testing in incarceration facilities or maybe other outreach settings. And again, that goes back to kind of that sustainability piece. So we're going to want to be mindful of a longer term data review. So maybe a 12-month period that will look at the quality of the testing that we're providing and the impact that we're having using some of these data points that we've discussed. And maybe even saying, hey, this information that we've collected, we've identified this social network or maybe this cluster of infection that needs more attention, and we need more resources to continue making an impact here. I see some comments in the chat. Let's see if we want to, do we want to look at them afterwards, Erin? I didn't look at them in detail. Or maybe Leo. We have just a couple more items. I guess maybe Erin, I'll turn it to you and then we can go to the chat.
Yeah, that's totally fine. So I have a couple of resources for program evaluation that I have found really helpful. Nonprofit Program Evaluation Made Simple is a book wrote by Shari Smith. And if you're interested in program evaluation and you want to learn a little bit more, this is a great entry point. She is very conversational. She's very helpful. She does a lot of webinar trainings, and I know she's on LinkedIn posting a lot. But she really breaks things down into digestible chunks that make sense. And it's been a really helpful resource. The next two resources are from CDC. One is the practical use of program evaluation among sexually transmitted disease programs. This is a deep dive into program evaluation. I find it as a resource of, I want to do A, B, or C, and I go to that section and look at it. Reading the whole thing together it's a good deep dive, but it's a lot of information. And then CDC has a second resource called Introduction to Program Evaluation for Public Health Programs. It's not as customized to STD or STI programs. It's a self-study guide. It's good information to get a basic understanding of program evaluation and how you can go through that 6-step cycle that CDC has laid out. Again, we'll share these slides, but I put QR codes here that'll take you to each of the resources. You can just scan them with your camera, and it'll take you to that website. So Amazon for the book and the CDC websites for the two other resources.
Thanks,
Now I think we're ready for discussion.
Yeah, so I see some great comments that are sentiments that other folks have shared as well previously. So someone says in the chat, I'm not sure what IMG is, that maybe the private testing, the private health folks. The program, there's another program that has taken over the jails, and they are not allowing them to test any incarcerated persons, even when they have positive cases to interview. They're having a difficult time. So yeah, it's a really great point that there are some additional barriers that we're facing when, even though we are needing to provide partner services or treatment. Angela, do you want to speak more about that, or does anyone have any other thoughts or maybe similar barriers that they've also encountered? I'm going to look in the chat as well. So someone adds also that the trends of overdose upon release from custody are literally off the charts. Any way to support OD prevention efforts are appreciated. So that's again using some of the data points that that we see at DIS to kind of expand our services. Barry, do you want to add more to that about what you've seen about overdose? I don't mean to put folks on the spot, but if you'd care to share, we'd love to hear.
Yeah. Do you hear me okay?
Yes.
Okay, perfect. So yes, get to know your jurisdiction, get to know what the overdose trends are. I actually wrote that in reference to when you were saying about partnering with other providers on the inside, which I think is really, really important. Regarding a private provider, again, I'm thinking the same thing, the IMG people and when public health gets squeezed out. If your jail medical provider is a for-profit vendor, then the two, then it's all in the contract. So you really need to work with the procurement department of either the sheriff's office or the county, because they're the ones that could really say, or even put in the contract that the vendor must partner with public health. And I've seen that done successfully. That's typically not something in the contract, but that's something that public health departments can indeed approach the sheriff or the county procurement office. It's finding out who monitors the contract with the private vendor and adding something to encourage partnership with public health.
That's really helpful. Thank you for sharing that. I wonder if other folks have kind of experienced the same thing too. But you're saying that that would be to go directly through the county or the sheriff's department, not through the jail or the jail health folks, specifically through the county or the sheriff's department.
The private medical provider is focused on the contract, their deliverables of the contract. It doesn't say partner with public health to do syphilis testing. They are not going to do it. Or dare I say, chances are they are not going to do it. There's no incentive for that. They're not being reimbursed. There's no check mark for them.
Thank you for sharing that. That's really helpful. Someone else wrote that they work with a communicable disease group as a nursing consultant on the corrections team. They've continued to work with jail developing CD disease guidance, and they've developed webinars, toolkits, and educational guidance. If you're able and willing to share, I think maybe folks may appreciate that in the chat as well, if you would like to add. Thank you for sharing that. Someone said, has anyone heard rumors of Narcan resistant fentanyl around the area recently? And someone adds a report about silencing units. Cool. What other questions are there? Are there any other thoughts around maybe some of these data collection points as it relates to DIS or maybe programmatically? Any other thoughts? What about other barriers folks have faced? I think it's so cool that, someone mentioned, hey, we've had trouble, getting partnership with the jails, because that's a question that's come up both in the first and second parts of the series. And so that's helpful information when you kind of see where we're all at. Sorry, I think if someone was speaking, I might have spoken. So in the chat, someone writes, we had a huge barrier after working with the jail for almost a year. We're no longer allowed to work to access adults in custody. There was a management change and the new lieutenant deems it dangerous for us to access the population. We were set to implement a testing and treatment program with our local clinical partner. The only time adults in custody are tested is if they request it or if it is indicated, which is rare. It has been very disappointing to have built a relationship with the medical staff and then have access cut off. I'm kind of curious to see how many other folks, maybe with a raise of, with the button, the raise hand button, can we maybe just get an idea if there are other folks that have kind of faced that, like you've already built a relationship and then there's been a management change, which we know happens so often in a lot of these settings. Oh, there's a lot. Okay. Oh, wow. Yeah, so it seems like there's a couple folks who have kind of experienced something similar. What are some things that you all have kind of done to whether work around it or maybe pause services? And this is an interesting question when it comes to sustainability of services, right? So often something like this will happen. And then we are really on, as much as our program and our team wants to continue testing, long term, this really impacts our possibility to do so. So what are some things that maybe you all have done around managing that once partnership and no partnership now?
If I may speak, with my local jails, I work in Michigan. They've switched from county health department ran clinics to privately owned clinics that are have previously been sort of really profit driven. The state health department has equipped our DIS with trainings to be able to kind of do everything that their clinic could do. So I'm certified to draw blood in the field. I can field treat them. They accept our medications, especially since the chain of custody is secured. They know it's coming from a state health department stockpile. And I have been given the opportunity to come in and draw the blood myself. I've often just been met with, we will deliver the treatment to them if you can give it to us, but we're just going to tell them to get tested when they get out. We're not going to test them or even bother, even if it's like an exposure to a primary syphilis case. They're really profit driven. So at least the state equips us to be independent operators when their hands are tied.
That's helpful. Thank you, Ryan, for sharing that. And I think I know that as a DIS, we kind of did something similar where we had the security access, but we also kind of provided that as like an incentive, like, hey, contacting the lieutenant beforehand or whoever the contact person was, like, hey, I can draw the blood on this person. I just need to get a lab on them real quick. How can I bring you the treatment? Maybe I can transport the bicillin to you if they don't have bicillin. Just kind of thinking about what ways can we close that gap, and how can we kind of close the gap on DIS and kind of maybe providing the phlebotomy or maybe treatment as well, like you said, Ryan, to ease the burden of moving pieces on whomever the jail health services folks are.
Yeah, it's absolutely very much like let us be in the same room. However, you guys need to handle that, and I will do the rest.
Yeah. What about partner services? How are you all kind of long-term looking at partner services when you are, looking at some of these facilities? I know it's hard, especially with folks maybe being released, or maybe these folks might be living houseless, or they may be unstably housed. How does that look like when we're thinking about kind of a longer term impact? Does the success of partner services impact anyone's programs in wanting to continue testing in jails? Any thoughts on that?
We have one comment that says it's very limited due to the inmate not having access to their phone or contacts or apps.
Yeah, that makes sense. I think oftentimes, even as essentially outside people, we don't have apps. We cannot bring our own phones in. We can't bring in, anything for us to even say, like, hey, here's Grindr, show me what you have or anything. Yeah. Okay, well, what other, I'll give maybe folks another moment to just ask or maybe just share other thoughts that they have if they want to add them in the chat. But if not, then I think we can probably wrap up. Erin, do you want to add anything to discussion before, or Leo, anything you want to add to discussion before we move to the next closing?
No, I don't, other than at the end, you'll have my contact information. And if you're interested in evaluation, if you have questions around evaluation, please don't hesitate to reach out to me. I'm happy to do technical assistance and help out, so I'm available.
Thanks, Karen. Someone adds to the chat, we'll do investigation and meet with the incarcerated person, but unfortunately we do have to interview through glass and use the phones. I know previously, just kind of looking through some of the feedback and the chats that folks had within parts 1 and 2, there was kind of a question of confidentiality when we are doing partner services and we are collecting that data, specifically looking at it from a data collection perspective, right? There are some items that we need to ask as part of even a very short presumptive interview, and how do we protect the information that we are collecting when we have to speak through a glass or use phones? Is there, I know that I've worked in a program where we specifically only spoke with individuals when they were in clinic. So the jail clinic would call the DIS and say, hey, they're here in clinic, I can keep them here for 30 minutes, and then the interview would be done there. But just other things to think about as you're thinking kind of long-term, but also planning. Okay, cool. I think we can go ahead and wrap up then. Thanks for sharing that last comment as well. So looking ahead at what to expect next, there's been, we all appreciate so much just the conversation and exchange that we've all shared together. And what we want to do with between the presentations, but also a lot of the concerns, questions, comments, insights that you all have shared is assemble a service delivery toolkit. So we're looking to have that together by the end of July. If you may have missed parts 1 or 2 or want to just look over them again, the slides and recordings are both available at the link there. I'm not sure if you can click it there, but it maybe, I'm not sure actually because it's on your screen. But if you go again to our website, ncsddc.org, you can access it there under events. And actually, I will put the link in the chat as well. And then lastly, I would like to send out an evaluation possibly for the whole series. So if you've been able to attend more than one part of the series, if you wouldn't mind again sharing your feedback, it really helps us to provide information that's helpful, but also kind of narrow down into information that maybe is more closely to what you're looking at. So thank you all so much. Chat here, I'm sorry, the link in the chat here before waste. Feel free to connect with each other in the chat as well as recording. But thank you all so much. I really appreciate you all. I'm going to go ahead and stop the recording now.